Today we have a journal club of momentum trial. I'm Mohammed Al Aboud, cardiac surgery resident, R3 in King Faisal Specialist Hospital Research Center. I would like to start one minute. So I would like to start with a quick review of Rematch trial, and then a quick review of HeartMate trial, HeartMate 2 trial, and then we get to Momentum trial journal club. In Rematch trial, actually the clinical question was, in patient with end-stage heart failure, does destination left ventricular assisted device therapy reduce all-cause mortality as compared to optimal medical therapy? The bottom line for the Rematch trial that in patient with end-stage heart failure, destination left ventricular assisted device therapy reduces all-cause mortality as compared to optimal medical therapy. The left ventricular assisted device therapy was first developed as a short-term mechanical circulatory support for patients with end-stage heart failure as a bridge to heart transplant. The randomized evaluation of mechanical assistance for the treatment of congestive heart failure, which is Rematch study, aimed to determine the suitability of LVAD for destination therapy. The in Rematch pulsatile flow left ventricular assisted device HeartMate was compared to optimal medical therapy, with the primary endpoint being all-cause mortality. Patients with advanced heart failure, NYHA class 4, left ventricular ejection fraction of equal or less than 25%, who were ineligible for cardiac transplantation. So the randomization were to receive an LVAD as total number of 68 or to continue optimal medical therapy as total of 61. The trial showed that left ventricular assisted device implantation was associated with a 48% reduction in mortality as compared with optimal medical therapy. The risk ratio was 0.52 with 95 confidence interval between 0.34 to 0.78 with p-value of 0.001, which is significantly makes different superior to the medical therapy. The survival at 1 year in the left ventricular assist device group was 52% as compared to 25% in optimal medical therapy with p-value of 0.002. The number needed to treat was 4. So number needed to treat is the number of patients you need to treat to prevent one additional bad outcome comparing to the optimal medical therapy. However, the difference was diminished at 2 years, 23% and 8% in LVAD and optimal medical therapy group respectively with p-value of 0.09. It is also important to note that the incidence of serious adverse events was higher in the LVAD group than in the optimal medical therapy group. The rate ratio was 2.35.
Ahmed?
Yes, Dr. Khabir.
How can you explain the last point?
Last point, the incidence of serious adverse events was higher in LVAD group than in optimal medical therapy, means that the incidence of adverse event is more in LVAD by 2.35 times of the optimal medical therapy group.
Why?
Well, because mainly is due to the patient is going for surgery and the implication of the surgery itself, the cardiopulmonary bypass, the anticoagulation.
So why the optimal medical treatment have less complication?
Well, I'm not sure about why exactly.
Somebody help?
Because there is no active or invasive intervention in the optimal medical treatment.
Anybody else? Haytham?
Yes, this is because of the surgery. When we implant the LVAD, so all the complication of that, namely the hemolysis because of the LVAD and the use of and acquired disease, and also because of the use of the warfarin, all that adds to the adverse events. Plus,
basically surgery.
Dr. Farid, because the most common complication of short-term LVAD in short period is the bleeding.
Okay, so patients who have LVAD will have complications, right?
Yes.
Well, the thing that you have to realize in this statement, the missing point, that the patients who have optimal medical treatment die. And if they die, they don't develop complications. So if I tell you, for example, let's say a theoretical issue. If you operate, you will have 10% survival in somebody else, let's say a group of diseases, whatever. If you operate, you will have only 10% survival with 90% mortality. But if you don't operate, you'll have 100% mortality. What's the complication rate in both groups? How do you compare that? You will find in the 10% who survive, they will have complications because of whatever interventions you have. But those who had medical treatment and they died, they will have zero complication rate. Do you see what I'm trying to say here?
Yeah, it's very clear.
Okay, go ahead, Mohammed.
Dr. Farid, don't they calculate the incidence based on the number of population on each group?
Yes, and then you have to look at which population did you look at. Did you look at them before or after? Usually they look at the beginning. Those patients went for optimal medical treatment. Those patients went for the LVAD. And those patients who died early, of course, they will drop off the equation, but they will also lower the number of the patients who will have the complications. So you have to pay, so you have to pay attention to this point. Reading this last statement will give you an impression that it's bad to have an LVAD.
Mm-hmm.
But actually it's good because those patients now are surviving. Yes, they're having complication. We may have to deal with those. Maybe in the future, one of you will find the solutions for that. But those who did not have the surgery, we lost them. They died. Okay, continue, Mohammed.
So this is what we conclude from rematch study result, that LVAD is better choice than optimal medical therapy for treating those patients. In HeartMate 2, the clinical question was, in patient with advanced heart failure, do a continuous flow left ventricular assist device improve survival free from disabling stroke and device failure as compared with pulsatile devices? So the bottom line here is that in patient with advanced heart failure, continuous flow left ventricular assist devices improve survival free from disabling stroke and device failure as compared with pulsatile devices. Here is the major point that the rematch and Intrepid trial evaluated the role of left ventricular assisted device in patients with advanced heart failure who are ineligible for heart transplant, as we mentioned. In rematch trial, patients who received LVAD had a 48% reduction in mortality as compared with medical therapy. Similarly, the Intrepid trial showed a significant survival advantage with LVAD as compared to optimal medical therapy. Here, the LVAD used in these studies were pulsatile flow devices with a large size and less durability as compared to new continuous flow left ventricular assisted device. In HeartMate 2 study, continuous flow LVAD, HeartMate 2, was compared to pulsatile flow LVAD for destination therapy. With the primary endpoint here of 2-year survival free from disabling stroke and LVAD failure. So the patients with advanced heart failure, NYHA class 3 or 4, left ventricular ejection fraction equal or less than 25%, treated with optimal medical therapy who were ineligible for heart transplant. Those were randomized to receive a continuous flow left ventricular assisted device, total number of 34, or pulsatile flow LVAD with total number of 66. The trial showed that the continuous flow left ventricular assist device was associated with increased probability of 2-year survival free from disabling stroke and LVAD failure, which was 46% versus 11% in the pulsatile LVAD group. The hazard ratio was 0.38 with 95% confidence interval of 0.27 to 0.54 with a p-value of 0.001. The continuous flow LVAD was also associated with significantly less major adverse events, including infection, device and non-device related, and right heart failure and an arrhythmia. The rate of hospitalization was also significantly reduced with continuous flow LVAD. So to conclude that after the study in rematch that the assisted devices are showing better outcome than the optimal medical therapy, they came after that with HeartMate 2, comparing it with the pulsatile flow, and they found that there is a better outcome with the continuous ventricular assisted device. In Momentum trial here, the clinical question was in patients with advanced heart failure, refractory to medical management, referred for durable left ventricular assist device placement. Is a magnetically levitated centrifugal flow device superior to an axial flow device with regard to reoperation for device malfunction or disabling stroke? So they were looking for reoperation or disabling stroke. The bottom line was in patients with advanced heart failure, refractory to medical management, referred for durable left ventricular assist device placement, a magnetically levitated centrifugal flow device was associated with 19.3% absolute reduction in reoperation for device malfunction or disabling stroke at 2 years. And this was driven primarily by a 15.4% absolute reduction in the need for reoperation for device malfunction, although there was also a 9.1% absolute reduction in overall stroke, but not the disabling stroke.
Hamad?
Yes, doctor.
Something for everybody to understand is the significance of labeling it as absolute reduction in the risk versus relative reduction in risk. I know it's not the time to discuss this, but everybody should be aware of those differences. Continue, please.
So left ventricular assist device are proven effective both for providing temporary support to patients awaiting cardiac transplant as a bridge to transplant, as well as durably improving survival and quality of life in patients who are not transplant candidates, those who are destination therapy. Since the original rematch trial, LVAD technology has improved with transition from first generation pulsatile flow device to second generation continuous flow device, which were shown in the HeartMate 2 to be associated with fewer mechanical failures and disabling strokes. Nevertheless, even second generation continuous flow devices are susceptible to mechanical complications such as pump thrombosis, which often results in need for reoperation. So here, magnetically levitated centrifugal flow devices may improve upon the earlier axial flow design by using a magnetic induction motor to generate flow centrifugally, allowing for wide blood flow paths and intrinsic pulsatility, factors that may reduce pump thrombosis rates. In a 6-month analysis of HeartMate 3 centrifugal flow device, there was an absence of pump thrombosis compared to a 10% rate observed with second generation axial flow LVAD. So here in a 6 months analysis, they show there was no bump thrombosis. And whether this difference persists in longer term follow-up or is associated with clinical events remained unproven. In the 2018 multi-center study of maglev technology in patients undergoing mechanical circulatory support therapy with HeartMate 3, Momentum 3 trial, randomized 366 patients with advanced heart failure requiring LVAD for either bridge or destination therapy. The left ventricular ejection fraction was equal or less than 25, as we mentioned, NYHA class 3 or 4, inotrope dependent or cardiac index less than 2.2 to the HeartMate 3 centrifugal flow LVAD or second generation axial flow LVAD. So at 2 years, the HeartMate 3 device was associated with a 19.3% absolute reduction in reoperation for device malfunction or disabling stroke, as we mentioned. This was driven primarily by a 15.4 absolute reduction in need for reoperation or device malfunction, which was in turn driven by 14.6% absolute reduction in bump thrombosis rates with the HeartMate 3. So the rates of disabling stroke and death were similar in both groups, although there was a statistically significant 9.1% absolute reduction in overall stroke, favoring the new HeartMate. Measures of heart failure symptoms, quality of life, and functional status improved similarly in both groups. Adverse events other than stroke or reoperation were similar with both devices, including rates of driveline infection, right heart failure, and bleeding. Here is the design of the trial. It is a multi-center, open label, randomized controlled trial. The total number was 366. HeartMate 3 centrifugal flow LVAD arm was 190, and HeartMate 2 axial flow LVAD was 176. The setting was in 52 sites in the US. The enrollment was from September 2014 up to November 2015. Duration of follow-up was 2 years, and the analysis was intention to treat, and the primary outcome reoperation for device malfunction or disabling stroke. Here is also only to highlight that the intention to treat analysis is a method for analyzing results in prospective randomized studies, where all participants who are randomized are included in the statistical analysis and analyzed according to the group they were originally assigned to, regardless of what treatment, if any, they received. So those who was assigned to get to the centrifugal flow LVAD were analyzed as they were having the centrifugal flow LVAD, and also for axial flow LVAD patients. The population included in the study, the inclusion criteria were age more than or equal to 18 years, body surface area of more than or equal to 1.2 meters square. The NYHA class was 3 to 4. Left ventricular ejection fraction was equal or less than 25%. The advanced heart failure defined as either of inotrope dependent patient or cardiac index of less than 2.2 without inotropes, and either of on optimal medical therapy for at least 45 out of 60 days, and advanced heart failure for at least 14 days, and dependent on intra-aortic balloon pump for at least 7 days. So those are the inclusion criteria for the trial. Here is the exclusion criteria, and they have set a lot of exclusion criteria. The beginning with etiology of heart failure. is like uncorrected thyroid disease, obstructive cardiomyopathy, pericardial disease, amyloidosis, or restrictive cardiomyopathy were excluded. Technical factors leading to inordinately high surgical risk were excluded. Existing durable mechanical circulatory support device were excluded. Pregnant women, mechanical aortic valve that will not be either converted to a bioprosthesis or overswing at the time of LVAD placement. History of organ transplantation was also excluded. Platelet count less than 100,000 were excluded. Psychiatric disease or disorder, irreversible cognitive impairment, or psychosocial issues likely to impair compliance with the study protocol and LVAD management. History of confirmed untreated abdominal aortic aneurysm more than 5 centimeters in diameter within 6 months, active uncontrolled infection. Also intolerance to anticoagulant or antiplatelet therapy or any other peri-post operative therapy that the investigator will require based on the patient's health status. Presence of severe end organ dysfunction or failure. Moderate or severe aortic insufficiency without plans for correction during LVAD placement. Pre-albumin of less than 150 milligram per liter or albumin less than 30 gram per liter. Also, planned biventricular assisted device support candidates were excluded. Known hypo or hypercoagulable state. Predicted survival less than 24 months outside of heart failure. So all of those were the exclusion criteria. Here is the baseline characteristics of the study. From the centrifugal flow pump group, those are the baseline characteristics for them. Age was, the demographics age is 61 years, a male 79%, the white 67%, black 27%. Comorbidities, body surface area of 2.1 meter square, creatinine of 1.4, heart failure ischemic 1 is 42%, left ventricular ejection fraction 17%, pulmonary capillary wedge pressure 24, cardiac index of 2, the pulmonary vascular resistance of 3.2, bridge to transplant 26%, bridge to transplant candidacy is 16%, destination 58%, and the other cardiac like AF 43%, stroke 8%, and history of CABG 23%, history of valve surgery 10%. So here I can show you the baseline characteristic of the patient was presented in the paper. And the only thing that I want to highlight that there were no significant difference between the groups except for history of valve replacement or repair, which p-value of 0.04, and systolic blood pressure of 0.01. Those are the only two differences between the characteristic of both groups. In terms of interventions, patients were randomized to 1-to-1 to both arms, as we mentioned. Randomization performed with the use of permuted blocks, stratification by study center. The data collected at 1 day, 1 week discharge, 1 month, 3 months, then every 6 months until 2 years. There was a recommended antithrombotic management, and both groups included aspirin 81 or 325 milligram daily, and warfarin for goal of INR 223. The NYHA class and 6-minute walk test performed by a trained technician used to assess functional status, and the primary endpoint assessed by as intention to treat, as we mentioned, but all secondary endpoints assessed as per protocol. The outcomes of the trial The comparisons, of course, were between centrifugal flow pump versus axial flow pump. The primary outcome were survival-free of reoperation for device failure or disabling stroke. 2 years non-inferiority, 151, which 79.5% versus 106 in total, which 60.2%. Absolute difference was 19.2 with 95% lower confidence bound of 9.8 with p-value of 0.001. The survival free of reoperation for device failure or disabling stroke at 2 years for superiority, 79.5% versus 60.2%. The hazard ratio was 0.46 between groups with confidence interval of 95%, confidence interval of 0.31 up to 0.69 with p-value of 0.001. So as a primary outcome achieved here, that the continuous flow pump has significantly a better outcome comparing the continuous flow versus axial flow. And they study it in two ways. First way that their question was about the non-inferiority, and they found it non-inferior. And for the superiority, also they found continuous flow superior to axial flow pump. Here is the Kaplan-Meier estimates of the primary endpoint and the intention to treat population. The intention to treat population included all the patients who underwent randomization. The primary endpoint was a composite of survival free of disabling stroke, with disabling stroke indicated by a modified Rankin score of more than 3. Scores range from 0 to 6, with higher scores indicating more severe disability or survival free of reoperation to replace or remove a malfunctioning device at 24 months after implantation. So rates of the primary endpoint and 6, 12, and 24 months, as we can see here, at the beginning, the difference was like only 7% between both group with steady rate dropping down. But as we reach 12 months, almost 14% difference. And from here, we can see that the event-free survival for the axial flow pump were dropped from like this point downwards. At 24 months, the difference between both groups were very significant. Here, in regards to actuarial freedom from stroke of any severity in the per protocol population. The per protocol population included only patients who received the assigned device implant. So it's not intention to treat as, but it is per protocol means that those who included here, those only received the assigned treatment. So the rates of freedom from stroke at 6 and 12 and 24 months as shown here, we can say that there is a steady free rate from stroke for the arm of the centrifugal flow pump compared to the arm of the axial flow pump, which is steadily decreasing from 6 months 88 to 12 months of 82, 24 months of 76. While in the other arm is 92, until 2 years is 89, the difference is only 3%. The secondary outcome here were reoperation to replace or remove pump 3, which is the HeartMate 3, 1.6% versus 17%, with hazard ratio difference between two groups 0.08, with 95% confidence interval of 0.03 to 0.27, p-value of less than 0.001. The disabling stroke was 5.8% versus 4% with hazard ratio of 1.45 with insignificant p-value 0.42. Death were also insignificant with p-value of 0.37. So in terms of disabling stroke only, there was no difference. But in total stroke between two groups, the continuous flow pump showed better outcome. And in terms of death and mortality, there was no difference. In terms of adverse events, suspected pump thrombosis was 1.1% versus 15.7% with hazard ratio of 0.06 with confidence interval 95% of 0.01 to 0.26 with p-value of less than 0.001. Any bleeding was 42% or almost 43% versus 52% with hazard ratio of 0.71. And it is p-value calculated is there was insignificant result to different, or there was the results were not significant to show difference between both groups. The right heart failure, 31% versus 27% with p-value, with insignificant p-value of 0.49. Ventricular arrhythmia was 23.8% versus 22.7% with also insignificant p-value of 0.8. So I would like to show this table, which showing the major adverse events in the per protocol population. So if we look to the suspected or confirmed pump thrombosis, it was 1 versus 15% with significant p-value. But in terms of pump thrombosis resulting in reoperation or removal of device or any intervention, there was zero intervention in the group of centrifugal pump with 12% intervention in the axial flow pump and significant result. Any stroke was also significant, favoring the centrifugal pump 10 versus 19%. Regards of the ischemic stroke, also there was significant difference favoring the centrifugal pump. The only issue that the disabling stroke, there was no difference between two groups. So what I conclude here that if any stroke or significant stroke happens to the patient in the centrifugal flow pump, shows no any better outcome favoring the centrifugal pump versus the axial flow pump.
Mohammed?
Yes.
Yeah, I'm not sure, but I think those numbers are from the early reports of the Momentum 3 trial, but the final report, which was published in 2019 March, actually both group they enrolled more patients, and each group had actually the centrifugal pump 516 and the axial flow pump had 512 patients, and they showed that which was powered enough to show and showed significant difference in overall stroke and in the disabling stroke also.
Thank you for the comment. I did not come across that update. So as Dr. Abdullah mentioned, I think there is an update after this original paper, which showing that more enrollment and that all, I think, according to you, Abdullah, that all the events are favoring centrifugal flow pump, yes?
Actually, it was showing the, I'm looking at it right now, I can send it in the group. It showed, 1 second. Yeah, in terms of, it was significant in terms of confirmed pump thrombosis, any stroke, disabling stroke, any bleeding, and in terms of gastrointestinal bleeding, and also in terms of cardiac arrhythmia and renal dysfunction. Sorry, renal dysfunction, it was not significant. It was, yeah, that's it.
Okay, thank you.
Otherwise, it's the same results.
Thank you, Abdullah. In the subgroup analysis here, there was no significant interaction between groups with regard to the primary endpoint was observed for the pre-specified subgroups according to age, sex, race, or ethnic group, intended goal of device therapy, or Intermax profile. Here is the criticism regards of the original Momentum 3 trial, that it is an open label design which allows for bias and outcomes assessment, which is particularly important with a clinically driven outcome, example, reoperation. For example, it is impossible that treating physicians were more likely to refer for reoperation in patients known to have the second generation LVAD. However, given the magnitude of the decision to embark upon reoperation, the effect of this bias is likely modest if present. The second point, that given only 2-year follow-up period, the effect of possible longer-term complications of the third generation device, example, the outflow graft twist or electrical failure, which have been described, cannot assist with certainty. I think with the update that Abdullah has mentioned, maybe this point might not be considered as a downside of the trial. In terms of funding of the trial, study supported by Abbott, maker of both the LVAD models studied. Authors with multiple ties to industry including a study sponsor. The sponsor provided devices studied and performed data analysis with verification by an independent statistician. Here only it's a very short video presented by Dr. Mehra and the American College of Cardiology.
I'm Peter Block here at ACC 2019 in New Orleans, and with me is Mandeep Mehra. And we have just heard about the Momentum trial. Now, Mandeep, you've talked about Momentum with me before. We've been through a number of iterations of this technology, and now we have Momentum 3, which clearly now has shown that the technology has made a quantum leap forward. So tell me about the trial quickly, and then let's talk a little bit about how these patients are faring.
Yeah. So Momentum 3 is the largest trial in advanced heart failure of left ventricular assist device therapy. It's a 1-to-1 randomized trial of a device called the HeartMate 2 device compared to the new device, the HeartMate 3 pump. The HeartMate 3 pump is a novel technology. It's a unique pump designed with a fully magnetically levitated rotor, and it makes it frictionless. The pump is much more forgiving on shear stress.
Yeah, that's what I was going to ask. Clearly decreases shear stress.
Clearly. And we also added a pulsatility component into the pump. So the pump pulsates by revving itself up and down.
You're making Mother Nature envious.
We're trying to mimic the biology as close as we possibly can. So this trial was really done to test this new left ventricular assist device, because we have improved survival in patients with left ventricular assist devices, but at the cost of a number of terrible complications along the way.
Yeah, thrombosis, hemostatic events, basically.
Really,
stroke, and all those bad things that happens when you have
things that stop clinicians from advancing the referral base for these patients.
There you go. So tell me what Momentum 3 has shown.
Yeah, so the 1,000 final report on these patients has shown that the HeartMate 3 pump with this novel technology is clearly superior to the older HeartMate 2 pump. How is it superior? If you quantify the net clinical benefit, for every 10 patients in whom we choose to place the HeartMate 3 pump, we avert 2.2 pump clotting events or pump thrombosis events, 2 strokes, and 6.8 major bleeds, of which about 4 of them are gastrointestinal bleeds. So it has a number needed to treat of less than 1.
I mean, that's crazy, right? It is that much better. So is HeartMate 2 going to continue to be manufactured, or is the company just going to move on and say, this is crazy, the results are so good?
Well, I think the results are so good that it is going to be crazy to de novo implant a HeartMate 2 over the HeartMate 3 if you had a choice. If you don't have a choice, or if you need to replace a HeartMate 2 with a HeartMate 2, then you may still need a few HeartMate 2 devices on shelf. But I don't see any choice but to pick the HeartMate 3.
You know, we were talking earlier about these patients and their thrombotic events and such. And the fact is, though, the mortality overall at what, 2 years?
Yeah, 2 years.
Is no difference between the two machines. So I was so impressed that we have come, the people who take care of these patients have come so far in dealing with their hemostatic thrombotic events.
Yeah, absolutely.
It's remarkable.
It's a great point. 81% survival at 2 years in these patients, and now a much more forgiving survival.
So you said earlier, they suffer, but they suffer from different things.
Yes,
right?
Exactly.
So in fact, their strokes go away, their thrombosis issues go away.
And bleeding.
And their bleeding goes away. And this is all a huge step forward technology-wise. Thank you so much, Mandeep.
Thank you, Peter.
So here we conclude, and thank you for the patient hearing. Thank you, Abdullah, for adding and comment. And if there is any question or any addition.
Thank you, Mohammed, for the nice, really nice presentation.
You're welcome.